Welcome to another episode from the Veterinary Research Channel. Today, we delve into a fascinating and perhaps underreported complication associated with a common procedure in equine medicine, the intravenous placement of over-the-wire catheters. This technique, frequently employed in horses for various medical needs, generally boasts a good safety record. However, like any medical intervention, it carries potential risks. One such risk, the unintentional loss of the catheter's guide wire within the horse's bloodstream, has been a subject of anecdotal discussions among veterinary professionals, but surprisingly has limited representation in formal scientific literature. Our exploration today is based on a recently published study that aimed to shed light on this very issue. This research, a collaborative effort involving multiple veterinary centers, sought to describe the clinical signs, diagnostic approaches, treatment strategies, and ultimate outcomes in horses that experienced intravenous guide wire loss during over-the-wire catheter placement. The authors recognized that the scarcity of published information left veterinarians with little concrete guidance on how to manage and predict the prognosis for these cases. Interestingly, the loss of guide wires during similar catheterization procedures is more extensively documented in human medicine. These reports often detail potential complications arising from a retained guide wire, ranging from disturbances in heart rhythm and the formation of blood clots to the risk of the wire perforating blood vessels or heart chambers, and even the possibility of infection or unexplained fever. Given these potential human complications, it's natural to assume similar risks might exist in our equine patients. The study we are discussing aimed to investigate whether this was indeed the case. The researchers embarked on a retrospective journey, meticulously reviewing medical records from several veterinary teaching hospitals and also reaching out to the wider veterinary community through professional listservs and social media platforms. Their goal was to identify as many cases as possible where an intravenous guide wire was inadvertently lost at the time of over-the-wire catheter insertion. To be included in the study, each case needed comprehensive medical records detailing the horse's signalment, that is, its age, breed, and sex, the reason for catheter placement, and the eventual outcome of the situation. Cases lacking these essential details were excluded to ensure the integrity of the data. After a thorough review, the study encompassed 13 horses in which an intravenous guide wire was lost, most commonly into either the right or left jugular vein during the catheter placement procedure. The ages of these horses varied considerably, ranging from just 1 year old to 19 years of age. Importantly, the study focused on cases where the guide wire loss occurred specifically during the placement of a 14-gauge over-the-wire catheter, and in all these instances, the catheters were inserted in the direction of the heart. Now, let's turn our attention to the findings of this research. One of the most striking initial observations was that none of the 13 horses exhibited any immediate, abnormal clinical signs directly attributable to the loss of the guide wire at the time it occurred. This is a crucial piece of information, suggesting that the event itself might not always present with obvious immediate distress in the horse. To understand the location of the lost guide wires, the researchers reported that diagnostic imaging was performed in every single case. The types of imaging employed included standard radiographs, which were used in 11 horses, ultrasonography in 7, fluoroscopy in 1, and echocardiography, an ultrasound of the heart, also in 7 horses. Plain radiographs proved to be highly effective in visualizing the guide wire, successfully locating it in 10 out of the 11 cases where this technique was used. In a majority of these cases, the guide wire was found within the jugular vein, in the region of the jugular groove. Ultrasonography was also successful in some instances, identifying guide wires within the jugular vein either at the level of the thoracic inlet, the opening to the chest cavity, or again in the region of the jugular groove, though with a slightly lower success rate compared to radiography. In a couple of cases, both radiography and fluoroscopy, a real-time moving X-ray, were utilized to pinpoint the guide wire's location. Given the potential for the guide wire to migrate towards the heart, 7 horses underwent echocardiography. This imaging modality revealed that in 4 of these 7 horses, the guide wire had indeed reached the heart. Interestingly, in 1 horse, the guide wire was initially seen in the right atrium, one of the heart's receiving chambers, but a day later, it had moved to a branch of the pulmonary artery in the lung. In another horse, the guide wire was found spanning both the right atrium and the right ventricle, the heart's main pumping chamber on the right side. A particularly detailed case involved a guide wire that had traversed the tricuspid valve, the valve between the right atrium and ventricle, with its tip lodged at the entrance to the right ventricle, while the other end was located near the entrance of the cranial vena cava, a major vein bringing blood to the heart. In a final cardiac case, the tip of the guide wire was lodged in the apex of the right ventricle. Follow-up echocardiography was performed on 3 of the horses where the guide wire remained within the heart. Reassuringly, these repeat examinations did not reveal any changes in the heart structure or in the location of the guide wire over time. Furthermore, several months after the initial guide wire loss, 2 of these horses with intracardiac guide wires underwent exercise electrocardiograms, which monitor the heart's electrical activity during exertion. These tests showed no evidence of abnormal heart rhythms or arrhythmias. Given the presence of a foreign object within the bloodstream, the next critical aspect was the attempt to remove the lost guide wires. Retrieval was attempted in 12 of the 13 horses in the study. Remarkably, these attempts were successful in 8 cases, representing 67% of the retrieval efforts. The techniques employed for removal varied. In 2 horses, a percutaneous endovascular approach was used, meaning the guide wire was retrieved through a small incision in the skin and into the blood vessel, often guided by imaging. The other 6 successful removals were achieved via a venotomy, a surgical incision directly into the vein. These procedures were performed either while the horse was standing and sedated or under general anesthesia. The percutaneous endovascular technique involved placing electrodes on the horse to continuously monitor their heart activity during the procedure. A specialized intravenous catheter was then inserted into the affected jugular vein, guided by either fluoroscopy or a combination of radiography and ultrasonography. Once the lost guide wire was located, typically in the distal part of the jugular vein, a specifically designed 4-pronged retrieval instrument was introduced through the intravenous catheter and carefully maneuvered towards the guide wire. The prongs of this instrument were then opened and closed in an attempt to grasp the guide wire. After potentially multiple attempts, once the guide wire was successfully secured, it was slowly withdrawn through the jugular vein and out through the intravenous catheter. Finally, the catheter and retrieval instrument were removed, and manual pressure was applied to the incision site to stop any bleeding. In the cases where venotomy was performed successfully, for horses underwent guide wire localization using diagnostic imaging before the surgical removal. In one of these cases where the horse was already under general anesthesia for an unrelated colic surgery, a magnet was used to help stabilize the guide wire within the jugular vein. A small incision was then made in the skin and the vein over the stabilized guide wire, allowing it to be grasped and removed. The vein and skin were then sutured, and the horse recovered without complications. Another horse underwent an unsuccessful attempt at guide wire removal under general anesthesia, but the following day, the guide wire was successfully removed via a standing venotomy. It's worth noting that only 1 horse in the study experienced a post-operative complication following a venotomy. This involved left facial swelling that resolved over several weeks, along with persistent blood clot formation, or thrombosis, in the left jugular vein. Despite the successful retrieval in 8 horses, in 5 cases, the attempts to remove the guide wire were unsuccessful, leaving the guide wire in place or in situ. The study provides specific details for each of these 5 cases. In one instance, despite an attempt at percutaneous endovascular retrieval, the guide wire, initially in the right atrium, migrated to a branch of the pulmonary artery. After consultation with a human medical cardiologist, it was decided that further invasive attempts were not warranted. Remarkably, 3 years later, this horse had no reported complications, and repeat echocardiography confirmed the guide wire remained in the same location without causing any heart abnormalities. Another horse had a guide wire that extended from the cranial vena cava into the right atrium, through the tricuspid valve, and into the right ventricle. Despite an attempted retrieval under general anesthesia using specialized grasping forceps and a basket retrieval device, the procedure was unsuccessful due to the guide wire's position against the vena cava wall and the free movement of its tip within the ventricle. Over the course of its hospitalization and in follow-up examinations up to 19 months later, including an exercise ECG, this horse showed no changes in heart structure or guide wire location and continued to perform at its previous athletic level without any reported issues. In a third case, a guide wire initially located in the right atrium and traversing the tricuspid valve defied 2 percutaneous endovascular retrieval attempts. Interestingly, during one attempt, Intermittent premature ventricular heartbeats were observed when the retrieval instrument touched the guide wire. This mare was placed on an antiplatelet medication until a follow-up examination a month later showed no heart abnormalities on a Holter monitor, a device for continuous ECG recording. She subsequently returned to dressage work and performed normally. Approximately 3 years after the incident, she was euthanized for reasons unrelated to the guide wire, and a post-mortem examination was not performed. The fourth horse with the retained guide wire was a pregnant mare. Echocardiography revealed the guide wire lodged in the apex of the right ventricle. An attempted retrieval using interventional radiology was unsuccessful. The mare went on to deliver a healthy foal without complications and remained hospitalized for an unrelated ocular condition for 6 months. 5 years after the incident, she was euthanized for reasons unrelated to the indwelling guide wire, and again, no necropsy was performed. The final case involved a guide wire that was located in the internal thoracic vein, rather than in the heart, after the initial loss in the field. Given its location, which was deemed relatively safe, no retrieval was attempted, and the guide wire remained in situ. 8 months later, the mare was reported to be doing well with no complications. Looking at the long-term outcomes for all the horses in the study, it's significant that all 13 horses survived to discharge from the hospital. Importantly, the presence of a retained guide wire did not seem to negatively impact the ability of horses to return to their previous level of work in 4 cases, nor did it prevent a successful delivery in the pregnant mare. Notably, among all the horses in the study, including those with successful guide wire removal, only 1 horse experienced a potentially related long-term complication, which was the persistent jugular vein thrombosis mentioned earlier. At the time of the study's writing, the other horses that underwent successful guide wire removal had not experienced any reported complications or long-term adverse effects, although the researchers acknowledged that long-term follow-up information was lacking for many of these cases. The longest reported follow-up period in the study was 10 years. The authors of this study then moved into a discussion of their findings, comparing them to what is known in both equine and human medicine. They highlighted that a significant proportion of cases in their study, 62%, achieved successful guide wire retrieval, either through venotomy or image-guided percutaneous removal. They also observed that guide wires located within the jugular veins were more readily retrieved compared to those that had migrated to the heart or surrounding vessels. The fact that successful retrieval occurred up to 4 days after the initial loss, in some cases, suggests that immediate, frantic intervention might not always be necessary. Drawing parallels with human medicine, the researchers pointed out that in humans, lost intravenous guide wires are often discovered incidentally years later during unrelated procedures, frequently without any associated clinical abnormalities or complications. They're finding that all 5 horses with guide wires left in place returned to their previous levels of activity without complications further supports the idea that intravenous guide wire loss in horses might not be as immediately life-threatening as some anecdotal reports might suggest. The study also briefly touched upon the Seldinger technique, the standard method for over-the-wire catheter placement, both in human and veterinary medicine. While this technique enhances safety by reducing the risks of air embolism and vein damage, it is associated with a certain rate of complications, including guide wire loss. In human medicine, interventional radiology techniques are the mainstay for retrieving lost guide wires, using tools like snares, forceps, or baskets, although surgical venotomy is sometimes required. Interestingly, the authors noted that similar to the situation in horses, intravenous guide wire loss is also considered a rarely reported complication in human patients, despite the larger volume of procedures performed. Regarding diagnostic imaging, the study confirmed that plain radiography was the most effective initial tool for locating a lost guide wire in horses, successfully visualizing it in all cases where it was performed. Other imaging modalities, such as ultrasonography, had lower success rates or required specialized equipment and expertise. This aligns with the standard practice in human medicine, where radiographs are also the primary method for locating a lost guide wire. The authors did acknowledge certain limitations of their study, primarily its retrospective nature and the lack of complete long-term follow-up in all cases, particularly those where the guide wire was successfully removed. The use of listservs to gather anonymous cases also meant that some medical records lacked the level of detail that would have allowed for more in-depth statistical comparisons of different treatment techniques and their outcomes. Despite these limitations, the study provides valuable insights. The finding that all horses in the study survived to hospital discharge underscores that the immediate prognosis for survival following intravenous guidewire loss is excellent. Furthermore, the successful removal of guide wires several days after the incident in some horses, without any migration or associated complications in the interim, suggests that immediate emergency retrieval might not always be necessary. Instead, a more measured approach focused on careful planning of the most appropriate retrieval technique might be more beneficial. In conclusion, this study, by examining 13 cases of intravenous guidewire loss in horses, offers a more comprehensive understanding of this complication than previously available. The findings suggest that while the event is undoubtedly serious, the long-term prognosis, even in cases where the guidewire cannot be removed, appears to be better than perhaps anecdotally feared. Plain radiography stands out as the most reliable initial diagnostic tool for locating the lost guidewire. Ultimately, the research suggests that intravenous guidewire loss during over-the-wire catheter placement in horses may be a less severe complication than previously assumed. Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.